Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the Department of Medicine. Today's Grand Rounds is entitled Learning Journey, Understanding and Improving Equity in Palliative Care. I'm old enough to hearken back to the days before there was palliative care. And I remember vividly when we established palliative care here at UCSF, probably in the mid-90s. And at the beginning, you had to explain to people what it was and why it was important. And now it has become completely essential, and it's almost hard to believe that we function without it. But that, of course, raises issues of equity. We are blessed at UCSF to have a spectacular group of palliative care clinicians and a wonderful division here at UCSF Health, but not everybody has access to the same quality and quantity of palliative care services that I think we've become used to and quite dependent on. So that will be what we hear about more today from two of our members of our Division of Palliative Medicine. The first is Sarah Nuri, who is an assistant professor in the division and who provides both inpatient and outpatient palliative care clinically and does research on largely the topic of today, equity issues in the field of palliative care. Sarah did her MD, if LinkedIn is correct, and at Southwestern, resident at Duke, and came here for her palliative care and research fellowships, and we were lucky enough to keep her on our faculty, so we're thrilled to have her. She'll speak first, and she'll be followed by Kara Bischoff. Kara is associate professor, also in the Division of Palliative Medicine. She's associate division chief for outpatient care and medical director of our outpatient palliative care enterprise. When palliative care began, it was all inpatient, and now obviously outpatient and home care are key components of what we do. So Kara's in charge of all of that. Clinically, she takes care of a range of patients with serious illness, including cancer, neurological diseases, heart disease, pulmonary diseases, and others. She's had a lot of her career focus, and her research has been on quality in palliative care. Kara did her MD at Harvard, came out here for residency, chief residency, palliative care fellowship. We were lucky enough to keep her on the faculty. So looking forward to hearing this. And I believe that Sarah's going to go first.
Thank you for the introduction, and thank you all for joining us today. We're really excited to talk with you about our learning journey, efforts to understand and improve equity in palliative medicine. We want to start off with our acknowledgements to the many people who have contributed to the work we'll be presenting today, and that includes our palliative care colleagues and our mentors across the Division of Palliative Medicine, the VA, SFGH, and the Department of Medicine, our patients and their loved ones, countless community members and partners, including the San Francisco Department of Disability and Aging Services and the San Francisco Palliative Care Work Group. We have no disclosures relevant to this talk. Our learning objectives today are to understand current disparities in advanced care planning and palliative care, and to consider approaches to improve equity and inclusion in palliative care. So what is palliative care? We'll start off with that. It's specialized medical care for people who are living with a serious illness. Our goals are to relieve symptoms and the stress of illness, and to improve quality of life for patients and also their loved ones and their caregivers. Palliative care is an interdisciplinary practice, and that can consist of nurses, advanced practice providers, social workers, chaplains, pharmacists, doctors, and others. And for patients, palliative care is available across the life course and across the serious illness continuum. So we can take care of someone who's 90 years old and has advanced dementia and is homebound, and we can take care of a 31-year-old who is getting curative treatment for breast cancer and is having severe symptoms like pain and nausea. And that's what sets us apart also from hospice, which is available to people who have an estimated prognosis of 6 months or less, and is focused on comfort care. Palliative care can be delivered in a number of settings on the inpatient side and the outpatient side, which will be the focus of today's talk. That includes clinic, telehealth, home-based palliative care, and facility-based palliative care. So since we're focusing on outpatient care, we wanted to tell you a little bit more about the landscape here at UCSF Health. We have two clinics. One is the symptom management service, where we see people who have cancer, and it's embedded in the cancer center. And the other is the outpatient palliative care service, where we see folks who have serious illness other than cancer. We don't have our own home-based palliative care program right now, but work with our affiliate organization, By the Bay Health, who provide home-based palliative care. And we do have a program also at the Jewish Home. One of the biggest questions is, who do I refer to palliative care? That's one of the biggest questions we get. And I'll say that we accept referrals for anybody who has a serious illness and a palliative care need. And palliative care needs can be difficult physical symptoms that are tough to manage. They can include help with emotional and spiritual coping around serious illness, and navigating medical decisions or complex advanced care planning. And the next question we often get is, what constitutes a serious illness? And this definition is not set in stone, and it may depend on the diagnosis to some degree, but essentially what we're referring to is a health condition with a high risk of mortality and that negatively impacts someone's quality of life or function, or excessively strains their caregivers. The benefits of palliative care have been shown in a significant body of literature. They include reduced symptom burden, greater engagement and advanced care planning, high value care, and that's specifically referring to lower intensity of care and healthcare utilization, and so reduced costs, especially at the end of life. Increased satisfaction with care and with communication, and also better quality of life, again, both for patients and their loved ones. Palliative care has also been shown to be associated with prolonged life. This is both in folks who are enrolled in hospice and in a landmark trial of people with advanced lung cancer who received outpatient palliative care. And lastly, we are a support also for referring providers. And this can be in a number of different ways. One is that by taking on things like complex symptom management and discussions about complex advanced care planning needs, we can really free up time for referring providers to focus on other aspects, other essential aspects of people's care. And while we know that all these benefits exist, we also know that there are tremendous disparities in outpatient palliative care and hospice. And these center in large part around access, utilization, and quality of care. So I'll give just a couple examples. In terms of access to palliative care, less than 50% of counties in the United States have outpatient palliative care programs. And this directly reflects the rural-urban divide of our workforce and our availability. In terms of utilization, this is now, disparities in utilization have been shown in all settings of how we deliver palliative care, so inpatient, outpatient, and also hospice. And as an example, hospice use among racially and ethnically minoritized people is only about 30%, compared with over 50% among people who identify as white. And quality of care, this also is an area where we see a lot of disparity. As one example, Black hospice recipients have 30% lower odds of having a visit in their last 2 days of life compared with white hospice recipients. And what all of this leads to, of course, are disparities in clinical outcomes, including worse symptom management, lower satisfaction with communication between patients and their clinicians, and higher caregiver anxiety, distress, and PTSD. And I want to take a moment here too to just note that in a review of all palliative care research from 2015 to 2020, our colleagues found that only 6% of the literature focuses on racial and ethnic disparities, and the proportion of studies looking at disparities in other areas, so rural versus urban or sexual and gender minorities, is even fewer. And so that's really the reason that much of the information I'm presenting here on this slide pertains specifically to racial and ethnic disparities. So why does this matter here and now? Of course, this matters as a core value and core tenet of the care that we're providing. In terms of the here and now, serious illness is a universal experience. All of the patients that we're caring for now or at some point in their lives are going to be dealing with a serious illness. And that's for everyone we're all caring for across the department. And we have a robust palliative care practice here at UCSF. As I shared, we see people in a number of different settings, and yet even here we're seeing disparities in access. And so it's critical that we understand the gaps in our practice in the context of our health system as a whole to really ensure that our community has access to high quality palliative care equitably. And this is particularly true as UCSF is growing rapidly and will be taking on the care of large new patient populations. So we've been working in our division to address these disparities at multiple levels, as demonstrated here in the socioecological model of health, which considers the individual, interpersonal, institutional, community, and policy level issues that can impact health. So we're going to be talking about a number of initiatives at each of these levels, and starting with community engaged advanced care planning. So we wanted to get a sense of what the landscape of advanced care planning is like across the Bay Area. And so we use geomapping to look at census tracts based on their advanced care planning rates and their neighborhood socioeconomic quintile. And here you can see a map of San Francisco, and census tracts that are outlined in Black are the ones that have both the lowest rates of advanced care planning and the lowest neighborhood socioeconomic status. And what we found in this analysis is that these census tracts cluster in neighborhoods like Chinatown, the Western Addition, the Tenderloin, the Bayview, and Excelsior, and Treasure Island. And for those of you who are familiar with San Francisco, you may note that these are neighborhoods that have the highest proportions of racially and ethnically minoritized residents and people with limited English proficiency compared to the rest of San Francisco. And so this led to discussions that we had with the Black, Chinese, and Latinx communities in San Francisco, who all demonstrated an interest in and a need for advanced care planning. And that led to a community-based participatory research project that we did with each community about advanced care planning. And the reason we chose this methodology is that community participation in research is critical for health equity. So in terms of the project structure and process, briefly, each community had an ambassador and a community engagement committee. The project overall was overseen by our team and the San Francisco Palliative Care Work Group. And I'll be sharing today a little bit about 3 steps from this project, from focus groups, which led to the communities designing events for advanced care planning, and then actually piloting those events. For the focus groups, we held 6 focus groups per community with older adults, caregivers, and community leaders. So starting off from the focus groups with the Black community, what we learned is that advanced care planning can preserve dignity, especially when it includes financial planning. And what folks were really referring to here is that the way that we think of advanced care planning as healthcare professionals is narrow, focused on health, and that really what people want to engage in is a broader end of life or broader serious illness planning that includes things like financials, estate planning, etc. Here's a quote from an older adult. "Traditionally in our community, we take care of each other. Insurances have ripped us off. So here again, we're talking about intergenerational wealth and disparities." We also learned that advanced care planning can strengthen families by fostering togetherness, that it can provide agency, especially for communities that are marginalized within the Black community too, so especially people who identify as LGBTQI+, and that advanced care planning events should be held in trusted spaces and led by trusted leaders. And one interesting finding that came out here is that trusted spaces included not only places that we often think of like senior centers or the library, but also local Black-owned businesses like the Jazz Room, for example, in the Bayview. Here's a quote from a community leader. "Small Black businesses can host these intimate working and informational exchange groups. People do want to come out. People do want to learn. We've got to bring information to where people are comfortable. That's who we are as a race." So the community committee decided to build on this last point and put out a request for proposal across their community to bring out new event leaders. And ultimately, they held 5 events hosted by these organizations that 114 people attended. And of those, 98% said that they would recommend events to others. So moving on to the Chinese community focus groups, what we learned here is that advanced care planning reduces family burden, that younger generations lack the tools to bring up advanced care planning with their elders, and vice versa, where older adults felt they didn't have the tools or the language to talk about advanced care planning with their kids or their other surrogates. Here's a quote from a caregiver. I think besides the seniors, events should also target their children, because sometimes they will just use the excuse of talking to their kids first, but their children may not understand what it is when they talk about it. They also noted that group events can increase social network influence and peer-to-peer sharing. So the Chinese community decided to build on what they learned in focus groups and connect advanced care planning to an aspect of culture to support intergenerational conversations over time. And so they built a tool based on the 5 blessings, which is something that many families reflect on at the time of the new year. And one of those 5 blessings is having a peaceful death. So they created this pamphlet that features grandma blessing in a number of different settings and with her family. And it asks questions like, what brings you the most joy and happiness? Or what does a good death look like to you? And the goal for this is really to get people to start reflecting on their values and to do that themselves and with their families. So 195 people attended 10 events. Half were in person and half were on Zoom because of the pandemic. And they were hosted by these 3 organizations. 96% of people would recommend events to others. And we also found in pre to post testing using a validated measure that advanced care planning, readiness to engage in advanced care planning increased after attending events. And then moving on to the Latinx community focus groups, what we learned from folks is that for advanced care planning to be successful, it has to have a culturally and linguistically appropriate approach. Here's a quote from an older adult. Advanced care planning went from being something strictly legal to something personal, but there was never a transition at the social level to create a cultural bridge, because this is a very American thing, right? They also noted, similar to the Chinese community, that sometimes older adults struggle in discussing advanced care planning with their younger surrogates, and that their community is not monolithic, and that there's marginalized groups within the community like LGBTQI+ and immigrant populations that may have unique advanced care planning needs. Here's a quote from a community leader. Some of my clients don't have family members. Also, for LGBT seniors, you know that we have a different sense of what family is to us. It may not be blood family. And so they drew on these learnings to really use cultural references in their advanced care planning work and to target different populations in their events. These are marketing materials that were created by a local artist, and I want to highlight that they used cultural imagery of Day of the Dead, and then also in the second poster intentionally included a diversity of families and individuals. So 97 people attended 4 events hosted by these organizations. 1 event was focused on older adults, 1 had an intergenerational focus, and then 2 were focused on the LGBTQI+ community. 90% of people said they would recommend the events to others. And again, in pre to post testing, we found that people had a greater readiness to engage in advanced care planning after attending events. So overall, we learned that it's both feasible and acceptable to move advanced care planning out of the health system and into the community with trusted leaders and in trusted spaces. Our approach to advanced care planning has to be tailored to include the most pressing needs for each group. For example, financial planning. We also learned that the LGBTQI+ population has unique advanced care planning needs, and this is an area of work for us in future, definitely. And currently, this work happened mostly in 2021, and currently each community is continuing to refine and test their advanced care planning interventions and developing new ones, and that's supported by a community grant-making project through the Stepsky Foundation. And I wanted to note too that our original hope in this work was to include both advanced care planning and palliative care. And interestingly, we heard from each community separately that they wanted to hold off on discussing palliative care and to just focus on advanced care planning as a sort of entry point. And the reason I'm bringing this up is because I think it's super important to understand why, as we think about how disparities in access and use of palliative care are manifesting. So people in each community noted that knowledge about palliative care was really low. And that attitudes towards it were mixed. So not everybody had a buy-in based on their understanding of palliative care. And they also importantly expressed concern that if we do education or teaching about palliative care, but people don't have access to outpatient palliative care services, then that's a huge problem. And so what we're doing now is working with the San Francisco Palliative Care Work Group and each of these communities to really delve deeper into palliative care access and capacity building across the county. And as we're doing that work, we're also taking a deeper dive into palliative care in our practices here at UCSF. So I'll hand that over to Cara to talk about that.
Thank you, Sarah. So yes, I'll talk about some of the work we've been doing to understand and progress towards equity here in our palliative care services at UCSF Health. So specifically, we did a comparison of which patients are being referred to outpatient palliative care and which patients are being seen for initial and follow-up visits to try to determine if there's any disparities in who we're reaching and who's being lost along the way. Almost 7,000 patients were referred to outpatient palliative care between October 2017 and 2021. Of these, 60% completed an initial visit, and of those who completed an initial visit, 66% returned for follow-up. In our multivariable analyses, we found that older adults, Latinx and Black individuals, those with Medicaid, and those who are unpartnered had a significantly lower odds of completing an initial visit after being referred to palliative care. Of those who established care with us, older people, men, and those with limited English proficiency were less likely to follow up. So we don't know that these findings are unique to palliative care. This may be true or similar in other clinics across UCSF Health, but certainly these findings were of concern to us. So in an effort to understand these findings, we performed a stratified analysis where we divided patients based on whether they completed their initial visit in person or by telemedicine. And of note, there were a very similar number of in-person and telemedicine visits conducted during this time period. What we found is that for in-person visits, many of the same disparities found in our overall analyses again showed up. But for telemedicine, there were far fewer disparities. In fact, for those who completed their initial visit by telemedicine, there were no significant differences by demographic characteristics in who established care with us. And being older was the only characteristic associated with the lower odds of returning for follow-up. So it seems from these analyses, at least in our health system, telemedicine may be able to decrease barriers to care and inequities. This is consistent with other studies summarized in a systematic review by Barbosa et al. That have shown that telemedicine can improve equity and access to care, especially for those with serious illness, profound disability, or geographic isolation, as many of our patients have. We've therefore been engaged in work to share best practices for telemedicine so that it can be optimized as a tool to improve access and extend care to those who need it most. A couple recommendations, just as examples, are having a video onboarding program to support people who have less digital literacy, get comfortable with launching a video visit, and to provide real-time support for the inevitable glitches that will occasionally arise during video visits, and using a telemedicine platform that's really user-friendly, with the ability to launch a visit in a single click, the option to use closed captioning, which is really important for people who are hard of hearing, and a chat function, which is important for people with dysarthria, as well as seamless embedding of video interpreters. However, the future of telemedicine is uncertain as our public policies around telemedicine are being actively reconsidered. For example, there's a pandemic era flexibility that allowed us to prescribe opioids after seeing a patient via telemedicine that was due to expire in May of this year. And if that had happened, it would have become illegal to prescribe opioids to someone who we'd met only by telemedicine and the prescriber hadn't seen in person. We were worried that this would lead to many of our patients who are homebound not having access to their comfort-focused meds. So we've been engaged in advocacy work, trying to share these real-world stories about how important telemedicine is to the care of our patients. For example, we shared a story about Sophie, who's an elderly woman who lives in a rural area of Northern California, and she has advanced ALS. She's essentially homebound and doesn't have funds to get out of her home in a wheelchair van. She receives all of her care by telemedicine, including a prescription for a low dose of liquid morphine that she uses for shortness of breath in the setting for respiratory failure. We also shared the story of Jim, who's a young man with lung cancer metastatic to his bones. He was referred to the symptom management service urgently when he had a pain flare that made it such that he couldn't make it to the cancer center to receive his cancer care. We were able to see him by telemedicine. After a couple of visits and titrating his opioids, he got to the place where he was comfortable enough to be able to make it to the medical center and receive his life-prolonging cancer treatment. It turns out that we're not alone in seeing these cases and feeling that it is important for patients, especially those in palliative care and hospice, to receive secure prescriptions via telemedicine. The DEA actually got an unprecedented 30,000 comments in response to this proposal that they end this allowance in May of 2023. So they therefore extended this flexibility until November to allow them time to review these comments and consider this further in light of emerging evidence. Sorry, just a moment. So these are a couple examples of how we're trying to work on a policy level to improve equity. But coming back to the institutional level, we've also wondered if disparities could be introduced at the level of referring to palliative care. Certainly, we appreciate that referring to palliative care is not as straightforward as referring to dermatology, for example. It can be sensitive, and it's sometimes difficult to know when's the right time. Some patients ask for palliative care, but we wondered if other patients have palliative care needs and don't know to ask for it. So therefore, over the past few years, we've tested several different models to routinely screen for palliative care needs in populations of patients and proactively offer services based on the needs identified. One of these models we call Care Plus. And in short, what we've done is first, we have an electronic screen that uses information in the EHR, so ICD-10 codes and utilization patterns, to identify Medicare patients with serious illness from a primary care population. Specifically, we did this at the Lakeshore Primary Care Practice, which is in the Sunset. Second, with the help of a care navigator, she calls and assesses patients for palliative care needs in the realms of physical symptoms, emotional distress, practical needs, advanced care planning needs, and family caregiver needs. And then based on the needs that are identified, the care navigator offers supportive services tailored to meet those needs. So for example, if a patient has emotional distress, they're offered support groups as well as time-limiting counseling with a palliative care social worker. If they have advanced care planning needs, they're offered an interactive advanced care planning website, prepareforyourcare.org, or advanced care planning workshops. And if they have significant physical symptoms or needs in multiple domains, they're offered a referral to palliative care. If a patient is interested in the referral to palliative care, the care navigator is able to pen this to the primary care doctor to review and sign if appropriate. Of note, we really tried to not impact primary care doctors more than necessary, understanding how busy they are. And the care navigator also called patients and family members back over the 6-month intervention to make sure that the services offered had met their needs and to see if any new needs had arisen. So we studied this program through a stepped wedge study, where of the 2,175 Medicare patients who were screened for serious illness, 292 were found to have a serious illness and were randomized to one of 3 cohorts. So in phase 1 of the study, during the first 6 months, cohort 1 received the intervention while cohort 2 was the control. And then the next 6 months, cohort 2 received the intervention and cohort 3 served as control. And finally, cohort 3 received the intervention. So of the 145 seriously ill Medicare patients in primary care that were reached by phone and agreed to enroll in an intervention cohort, the average age was 75, half were women, about 40% were Asian, and 83% were English speaking. These demographics were really representative of the Lakeshore primary care population overall. And the most common categories of serious illness in this population were cardiovascular disease, cancer, diabetes with end organ damage, and dementia. Many seriously ill patients had more than one illness. In these patients, we found that 64% reported symptoms that were impacting their quality of life or function, and 28% reported their symptoms as severe. So these patients with severe symptoms or with needs in multiple domains were offered a referral to specialty palliative care by the healthcare navigator, and about half of those offered it accepted the service at that time. Of note, the 17% of people who were referred to palliative care during an intervention phase is compared to the 7% who were referred during a control phase. 58% of people had emotional distress, significant emotional distress, and about a third of these folks were interested in a support group or time-limited counseling by a palliative care social worker. 38% reported a stressful practical need, and about half accepted support from a palliative care social worker to help them with that need, and about 57% had an advanced care planning need. All of these patients and families stayed on the line and had an introductory conversation about advanced care planning with the healthcare navigator, which was documented in the EHR. And about 2/3 were interested in the advanced care planning website or workshop. So importantly, we found no differences in the rate of palliative care needs by racial, ethnic, or linguistic group in this study, although admittedly, we may have been underpowered to identify subtle differences. There were also no differences in the rate that services were offered to or accepted by patients of different demographic groups, except that the support group, which was only offered in English, was more often accepted by English speakers. With this intervention, advanced care planning increased significantly, and quality of life was preserved during the intervention phase, while it was found to decline during the control phase. As a next step in this project, we're now engaged in what we're calling Care Plus 2.0, which is a similar program that we're rolling out in the gynecologic oncology and movement disorders clinics. And this time, the assessment of palliative care needs is occurring via an electronic survey that's being sent via MyChart. And from our experience so far, we're finding that this makes the screening process much more efficient. But as we gain more experience, we also want to assess whether this method of assessment reaches everybody equally. So to summarize our high-level learnings from this project, routine screening in populations of seriously ill patients can identify a high frequency of palliative care needs. And some, but not all, patients are interested in services to address these needs when they're offered by a healthcare navigator. So we've shown you a couple projects that have revealed that many people with palliative care needs don't yet receive specialty palliative care, but we also wanted to consider how are we doing with the patients who we are seeing? And what can we do to make our care more inclusive for diverse populations? So to do this, we conducted a semi-structured interviews with people of color who are seen in our outpatient palliative care service and their family caregivers. Most shared that they didn't know what palliative care was prior to their first visit. So stigma about palliative care actually didn't seem to be a major barrier in these individuals. They also reported that attending the first visit was logistically easy. They appreciated having the option to do telemedicine and having the routine use of interpreters. While we set out to learn really what we can do better to make our care more inclusive, instead what we heard from people was that all of them had a high degree of trust in the palliative care team. So kind of switching the project a little bit, we sought to really evaluate what specific behaviors were helping to promote trust with these people of color. And what we learned fits really well with the intensive caring framework set out by Dr. Harvey Chochinov. He's the father of dignity therapy based in the University of Manitoba in Canada. And in defining intensive caring, he explained that it involves reminding patients who may be feeling helpless, hopeless, or worthless that they matter. Even when they feel life is no longer worth living, we, their healthcare professionals, must affirm their intrinsic worth for all they are, all that they were, all that they will become in the collective memories of those they will eventually leave behind. So one of the core elements of intensive caring is showing interest in patients and family caregivers, including with the use of curiosity. So one of our patients spoke to this, saying, they know my children by name. They even ask about them. They give me the impression that they not only look at me, but they understand what my children are going through. They're very supportive. And one simple way to integrate some of this into your practice is to use the patient dignity question. What do I need to know about you as a person to give you the best care possible? This has been shown to only take a couple minutes and to help patients feel like they're seen as a whole person, not just an embodiment of their disease. It also helps elicit patients' values. Non-abandonment is another element of this intensive caring model. And this comes from being reliable, responsive, and readily available. An example that a caregiver highlighted is the fact that the social worker was able to relay to us the sense of mutual understanding. It felt like, okay, people are trying to help us. They're not just here to talk. And I communicate with them pretty much on a weekly basis. We acknowledge that being reliable, responsive, and readily available is something we all strive for. It also takes adequately staffed teams, and I know that that's something that we're all striving towards. A third element is therapeutic presence, being compassionate and empathic, genuine and authentic, trustworthy, and fully present. A patient commented, "As I got to gel with them, I've created a bond. I look at most of them more like family members. In my line of work, you learn how to read people, whether they lie to you or not. They've been very accurate. Matter of fact, we have good laughing talks. So it's not just 9 to 5 work related, there's a bond there." And a caregiver commented, "They seem very open and receptive, very caring. They listened carefully and thoughtfully." One example of how to create therapeutic presence is to express genuine empathy when appropriate and acknowledge the emotions in the room through a statement such as, "I'm so sorry this is happening. I can't imagine how upsetting this must be." A fourth element is therapeutic humility, tolerating clinical ambiguity, accepting the patient's expertise, and engaging in non-judgmental shared decision-making, which we heard from a lot of people. A caregiver commented, "She gets our opinion as well. So it's not just like her pushing something on us. Rather, it's her trying to educate us based on her knowledge and our knowledge." Humility can be expressed in practice by asking for permission before sharing prognostic information. Along the lines of, some people want to hear a lot of information about what's to come with their illness. Other people don't want that information, prefer to take things one step at a time. How much information do you want to hear at this point? And finally, holding hope. A caregiver shared, "They always encouraged my mom to, think positive. So you feel, because of how much they care about your mom, how they want her to think positively, you feel like you can trust them." A question that I often ask to understand and support a patient's hope is, as you look to the future, what are you hoping for, no matter how severe their illness? In our interviews, we also heard a couple additional themes that aren't part of the intensive caring framework, including that people really appreciate well-coordinated team-based care, and that patients and family members are appreciative of having diversity on the palliative care team. Their ethnicities are different. So, I'm dealing with a multiracial kind of soup here, and I love it. I wouldn't change any of the ingredients. So this, particularly this last finding, has really underscored for us the need in our division of palliative medicine to continue to diversify our workforce. Sarah's going to tell us a little bit more about that.
Thank you, Cara. So to start, just want to share a little bit about the state of the palliative care workforce in general. About 12% of recent fellowship graduates identify as Black, Hispanic, or Native American and Alaska Native. And this proportion is similar to the average proportion across medicine as a whole, and it's something that we want to change. I also want to share that about 10%, when we look at all palliative care clinicians, so not just doctors, but also social workers, nurses, chaplains, that about 10% identify as Black, Hispanic, or Native American and Alaska Native. And this is notable because, like I described at the beginning of the talk, we are an interdisciplinary practice. And so when we look at clinicians overall, it's where some of these differences become more apparent compared to the rest of medicine as a whole. So for example, among nurses in the US overall, this number is 20%. Among social workers overall, it's over a third. And so we have undertaken a couple initiatives in our division to diversify our workforce. One is that we have a summer research program for UCSF medical students between their first and second year who identify as underrepresented in medicine. And what this provides is a summer-long funded research project with dedicated research mentorship, as well as clinical experience on our different services. We also have a summer program for underrepresented in medicine undergraduate students. And this is a month-long program that is mostly focused on clinical exposure, on our inpatient, outpatient services, and also on hospice with By the Bay Health. And it includes career mentorship that's meant to be longitudinal, going years, hopefully beyond this 1-month program. And then in terms of fellowship recruiting and hiring of faculty and staff, we engage in a holistic review process and really focus on recruiting people who reflect our patient populations in a number of ways. Part of the work of centering equity in our division also includes looking at an individual level at our culture and our individual implicit biases. And so I do want to highlight a number of initiatives that we're undertaking for internal culture change within our division. One is the Anti-Racism Task Force. This was established in 2020 by 3 people in our division who, it's an interprofessional group, 1 physician, 1 social worker, and 1 administrator. And the goal of this group is to evaluate our current status in our group's skill and fluency in discussing and addressing issues of bias, justice, and oppression. And really the discussions span from micro to macro levels. So we explore our own experiences and consider how they might influence our clinical work and our personal relationships and professional relationships, and consider the learning needs of our division as a whole. And part of what came out of this work is a new, as of this year, Associate Chief for DEI role that I have the honor of serving in now, and the formation of a dedicated DEI council. We also have a women's council started by a physician and social worker, another interprofessional group. And this group similarly spans micro to macro issues for women in our division, and also brings in speakers and women leaders in our field for discussion and for small group mentorship. And then we have a new social justice fellowship track. Last year, we implemented a social justice curriculum for the fellows that all fellows receive as part of their usual didactic series. And then this year, we have this dedicated track that's gone into place that's optional for fellows. And then it includes the usual curriculum that I just mentioned, and also allows fellows to spend some elective time focused specifically on a DEI-related initiative or research project. I want to speak briefly to our upcoming initiatives for this year. One is to build on existing UCSF curricula, to develop faculty and staff workshops on how to incorporate DEI into teaching and how to be an upstander, especially in challenging palliative care clinical scenarios. To maintain a space for honest and open communication about anti-racism and other oppression, we're establishing a DPM inclusivity forum that will meet monthly for lunch. And then we're really focused on building out our community partnerships this year. So that's with specific community-based organizations and also with the San Francisco Palliative Care Work Group as a whole, which, as I mentioned earlier, is a collaborative of folks that include community leaders, community-based organizations, and representatives from our local government. And part of this community work is also diversifying our Patient and Family Advisory Council, who provide tremendous feedback and insight into our work as a division, ranging from our clinical work to our research. And so we do want to make sure that the patient populations we're caring for are represented on this council. So we've shared a number of initiatives at each level of this model, really to give a sense to you all about what we're working on and what we're striving towards, and also to just say that we're very open to collaboration and learning with and from other divisions in our department. And really high level key points from what we've learned so far. We've learned and learned again that engaging the community to determine what issues, is it critical for determining what issues to address and how to address them. We know there are disparities in who accesses our services, and we know that telemedicine can actually be one tool to improve equity and access and utilization. We've also learned that population-based screening that we've done so far has revealed that palliative care needs are common in patients with serious illness. And so really thinking about equity from the moment of referral or even before is a critical component of this work moving forward. Workforce diversity is both something that our patients appreciate, and it's something that requires an intentional approach to maintain and to grow. And our goal really is to embed equity in all of our missions as a division. So in conclusion, as Dame Cecily Saunders, who is the founder of the modern hospice and palliative care movements, famously said, "You matter because you are you, and you matter to the last moment of your life." And in working towards equity, We're trying to make sure that all our patients, our entire community, can feel that this applies to them and that they and their loved ones get the care that they want in the face of serious illness. So thank you for joining us.
Questions here? Good. Thanks so much. That was inspiring and a lovely mix of data and stories to get up to make a lot of really wonderful points. Let me start with a few. One thing you didn't mention about telemedicine, but I suspect is a driver of improvement and maybe to some extent equity, is I assume it's easier to engage family in visits through telemedicine than it is in person. Is that right? And sort of how is that playing out?
Yeah, I would say that a very high percentage of our patients present with a family member, both by video and in person. But I think that those in-person visits can be very burdensome for family members. Often the patients we see come from a very wide geographic distribution area, and they have to travel a distance. And that can be really hard for people to take time off work to travel. So I do think it's true that telemedicine is a lot easier on family members as well as patients. It also allows us the opportunity to involve a broader range of family members. So the daughter can zoom in from New York, or the son can zoom in from Texas, et cetera. And so we can often gather a wider group of family members, which can be appreciated by patients.
Great. Anything to add? No? All right. I imagine everybody who's in other practices is wondering, you're out there soliciting more patients, and in our practice, the waiting list is 6 months to get in. So if all of these people that you're finding care gaps who might benefit from palliative care said, yes, you're right, how is it that your practice is not getting overwhelmed?
Does it work?
Yeah.
No, that's a great question, and I'm sure you can speak to that, Cara, too, as our outpatient medical director. It is certainly an area where our physician workforce in palliative care is limited, and so really growing not just our physician workforce, but our interdisciplinary workforce is key in the coming years. I think we also do have quite a bit of patient turnover, which makes space for new folks, but I'll let Cara.
Yeah, I think we basically have been growing really rapidly in the outpatient space. I recently put together a graph of our visits since 2005, and it's just been a straight up line that doesn't show any sign of flattening
And
out.
what percentage is telemedicine these days?
We're at about 95% telemedicine at this moment in time, yeah.
And so can you continue to grow? And as Sarah's point about it's not just all doctors.
Right.
How do you figure out, I imagine there are times where it's sort of any member of the team will be fine. And there are other times where you actually want a specific member of the team to address the specific problem. How do you make that sorting work out?
And it's often Greg, our social worker.
Greg's the
very
answer?
hard. But
Answer.
yeah, it's a very active work in progress to try to advocate for full interdisciplinary teams and keeping those growing on pace with the rate that we're adding physicians, as it is easier for us in our system to add physicians to continue to match the demand. But it's harder to advocate with the health system about the value of social work. But
Easier to add physicians, so just everybody's talking funds flow these days. Easier to add physicians because the sort of funds flow works out and there's enough
because
resources to hire. They can generate
RVUs
essentially their salary.
to help cover their
Whereas
salary.
for the health system, you need to get someone to say, yes, we want to have
Yes.
another case manager, social worker, nurse.
Exactly. So, and it's not just harder to hire social workers, but also nurses, chaplains, et cetera. And so one thing we've done is done some analyses that show that for people who are seen in our outpatient palliative care practice, there's significantly less inpatient utilization in the next 6 months compared to the 6 months before they met us. And that data, the 30% reduction in hospitalizations and hospital days, was helpful in bringing to the health system to demonstrate the value of our full interdisciplinary team and how the savings are not just, or in the impact on the finance of the health system are not just in the RVU we generate, but also the fact that we're getting people the care they want, which is often care outside the hospital, keeping people out of the hospital. But it's work in progress. So.
I just want to add too that several folks in our division are working on testing out group medical visits as a potential model too, to be able to see more folks within a similar time period as maybe you would see 1 or 2 people to seeing a larger group. And so we're currently looking at that and evaluating it to see how that works. So that's another way that we could increase capacity.
Also via telemedicine or in person potentially?
There, for now, via telemedicine, maybe one day in person, but I think from a feasibility standpoint for our patients, telemedicine is probably going to be the way to move forward.
Okay. I think there's probably that there is something that might have some truth in it. It might be mythology / bias about different racial and ethnic groups have very, very different attitudes about end of life care and about levels of aggressiveness. Or do you see that in your research, and kind of what should we know about that? Because I suspect some of it is quite real and some of it may just be kind of old saws about the way different groups think about end of life care.
Yeah, I think that's a great question. I think there is truth in cultural values having a huge impact on how we think about our end of life and how we think about serious illness, even not just at the end of life, but how do we really care for ourselves? How do we care for family? What information do we want or not want to hear? So I think there is a lot of truth in that. And one thing, especially I think to point out around, there's a big issue, of course, around kind of mistrust and lack of trustworthiness of our health systems, given historical and current context. And that can often be, you know, in terms of certain groups wanting more intensive end of life care, there is a tension between the thought that potentially people are withholding, that healthcare systems are withholding care or trying to push people away towards getting care. And that can contribute to wanting more intensive end of life care. And so I think this is an area that we're actively exploring and working on with communities. You know, one thing we learned is that people have really mixed attitudes towards palliative care in the community. And so this is an area to definitely unpack and explore more.
It was interesting that you said that it was sort of a positive. They didn't know anything about palliative care. They didn't have a bias against it, because that would be my concern. You know, palliative care, does that mean I'm dying?
Well, and
but
I think
it sounded like that was not so much the case.
Yeah, and I think that's true for the people that ended up coming to see us in clinic, that there wasn't that bias. And of course, we wonder, since we did those interviews with people who are our patients, we of course wonder what's going on for the folks that didn't establish care with us.
Yeah.
And that's kind of a harder group for us to reach, but an important one that we're working on thinking about how to reach out to. So
Right.
I think, yeah.
One more question for me, then we'll open it up. One of the things you have done, I think, uniquely well is this interdisciplinary team of lots of different people who bring different perspectives. And a point you made is often we're missing one piece of that, which is financial planning. And that's sort of a big deal for people, which I completely get. So are you adding that to your team? And how do you draw the line between this is a healthcare-y thing and this is a non-healthcare-y thing when it's all kind of blended together?
Yeah, we haven't added anything yet. And I think our social workers do a phenomenal job addressing those issues. So making sure that people do have time to spend with our social workers. There are a number of models for medical legal partnerships where people can get more advice. And there's several community organizations that offer really low cost legal advice or free legal advice for this issue. So we do try to incorporate those resources, but haven't developed a new dedicated way to do that in our practice. And I don't know, I guess what we've learned is for some folks, they don't really want to draw the line between healthcare or other aspects. So I don't know that we need to draw that line since caring for someone with serious illness really involves all of these it involves their whole socio-political context. So
yeah, no, for many people, it's the thing they're worried about the most.
Absolutely.
Yeah. Anything to add? Great. All right, let's open it up for any questions from here or from Zoom world. Lakshmi, anything? Yeah.
Yep. So one of Dr. Schroeder asks about, could you talk about the funding of the palliative care team, both from the patient side and also from your whole team side? How does it work in the outpatient world?
Sure. Yeah, so from the patient's perspective, coming to a palliative care visit is like coming to another specialty visit. So they have the same co-pays that they'd have at another specialty medical visit. Funding the the team from our standpoint is difficult. I think, we've been lucky to have really strong champions, many of whom are in this room that have been really helpful to us over many decades, who understand the value of this team-based care and understand why it has to be transdisciplinary and to be done right. And that's been invaluable. But it does feel like it's an ongoing battle. It's not necessarily getting easier in time. So yeah, we're just trying to continue to prove the value of what we do and to specifically highlight the value of each member of the team. If I could use this opportunity to just highlight, for example, our social worker, Greg, who I've already mentioned, has seen 2 patients in recent months where he was able to identify that they actually qualified for Medi-Cal, that they hadn't previously had. Those patients got Medi-Cal and then one of the patients went on to get a liver transplant that they were previously not eligible for because they didn't have insurance. So it was a life-saving social work intervention, and sort of telling these stories and about why we need all members of our team is really important.
Right. And can you just, one thing that came up is you talked about the finances in hospice and the line between your services and hospice when you think and the patient and the family believe that hospice is right. Do they leave your care and go to hospice? Is that how it works?
Yeah, generally, we do transition the vast majority of our patients to hospice. That being said, if we have a longstanding relationship with them, we often stay involved as the physician supervising their hospice care. And we're very comfortable doing that with a lot of the local hospice agencies, and patients and families tend to really appreciate that, having us staying involved. And if you're listed as the doctor overseeing their hospice care, you can continue to see them for billable visits throughout the care and communicate with their nurses. It
I
works
was
really
under the
well.
impression you sort of had to hand them off to a whole separate entity. It sounds like not.
Right.
Yeah, great. Okay. Other questions or comments? Anything else?
Yeah, one more question about this concept of privilege, and how do you talk about that in clinic, especially when you're reaching out to patients or groups in the community that are of different identity than yours?
Yeah, that's a really important question. And I mean, certainly addressing, naming our own positionality to this work is important. I think key to building community partnerships is humility. It's really a partnership. I think we approach it truly, at least in my work with community-based organizations, as a true partnership where we both have something to learn and we both have something to offer. And I think that's been a good way to approach it. And I think from a research standpoint, I briefly highlighted just why community-based participatory research can be so essential. And really what that entails from a methodologic standpoint is engaging your key community members from the get-go, from the very beginning of the idea that you might have, and then including them in every step of the research process. And at the same time as you're doing the research and evaluation work, doing capacity building so that there's some sustainability in the work that you're offering over time. So I think hopefully that answers the question.
Great. Okay, I think we're at the hour. Thank you for a great talk and thank you for the really important work you do. Appreciate it.
Thank you.